Well, Alex, it's a great relief to all of us to see your presentation here. Alex, it's very nicely going to fit in somewhere between what Warren was talking about and what Adrian and Mark were talking, because it's the integrated care journey. So I'll hand over to Alex.
Good afternoon, ladies and gentlemen. I'm Dr. Alex Wu. I'm the clinical director in acute medicine in the Royal Free London NHS Foundation Trust. And I'm a consultant geriatrician by trade, but I'm also the clinical champion responsible for delivering the integrated care program for my division in urgent care. My talk is to tell you about our journey into integrated care which started 2.5 years ago. And this will cover what is integrated care, why do it, what is involved, how we do it, what did we learn from it, and how do we evolve from our learning, followed by summary and conclusions and hopefully a bit of time for questions at the end. Just a bit about the Royal Free. We are a teaching hospital in North London, and we're also a busy major acute hospital with £550 million turnover a year, and we employ 5,500 full-time staff with a capacity up to 900 beds. We're licensed as a foundation trust in April 2012, which gives us some financial autonomy and also some control over our own destiny for the first time. This is my definition of what I think integrated care is meeting the needs of individual by flexible and seamless working across multiple organizations to deliver optimal and personalized care, whether in the hospital or in the patient's own home. We have to do it partly because, given the current economic environment for the NHS, everybody's very cash-strapped. It is imperative that we achieve best-in-class in clinical productivity, which is measured by length of stay, readmissions, and excess bed days. Continue working the way we do, where all the patients coming to A&E are admitted into a ward. They have to wait a long time for investigation and treatment, and then wait for a social care package to go home. It takes a long time. It won't actually help us to improve the productivity. So doing more of the same is no longer an option. We need to find a new model of working which is going to shorten this journey. We need to eradicate all the inefficiencies, duplications, and all the silo working which is rife in the NHS and bring the care closer to the patient's home. This means that we have to resign all our clinical pathway completely, focusing on patient's cohort, which will result in length of stay reduction and admission avoidance. The senior management team of the Royal Free already know our future lies in its extension to community, and we already started working very collaboratively with all of our community partners. We're possibly the first trust to appoint a director in integrated care, and I can really describe this person as a very entrepreneurial and very brave person, because she's very keen to commission and fund any innovations that is going to develop and test this new way of working. Even without upfront clinical evidence, this is value for money. So clinicians like myself have been invited to come up with new models of working, which is going to break the traditional mode of working, and this is exactly what we did in 2010. The two innovations that we did, the first one is post-acute care enablement, which we call PACE, which is an early supported discharge service. And this is set up in order for our second innovation to work, which is Triage Rapidly Elderly Assessment Team, called TREAT, which is an admission avoidance team based down in A&E. And PACE is necessary to enable TREAT to function. The patient's cohort chosen for these two innovations is our complex elderly acute medical emergency admissions. And we see a lot of these patients in North London, because we have very old population living in this district. The majority of these patients get admitted into the hospital, and once they are admitted, they have a very, very long length of stay. The department involved is my own department, which is Health Services for Elderly People, we call HSEPT. We see 3,200 emergency admissions per year, which represent 40% of the acute medical take. We have a lot of chronic long-term conditions, and certainly we have a lot of patients coming from care homes. The care home patients represent 20% of our acute medical admissions. And this is because North London is a net importer of a lot of older people who come and live in all the care homes in our district. And at any one time, we have 2,000 care home patients in our area. And they come with variable acuity. Some of them are very simple infection, like a urinary tract infection, and it ranges from that to septic shock that needs to go to be admitted to intensive care. We aim to deliver a different model of care which will reduce admission, focus on early supported discharge to shave the length of stay, and has to be safe and has high quality, but in a lower cost setting, and that is really in the community, in the patient's home. The funding of these innovations comes from the closure of an 18-bedded acute medical ward. I was appointed clinical champion, and our lead in service redesign is appointed project manager. And we kickstart in May 2010 by inviting all our community partners to a brainstorm meeting. And I'm ashamed to tell you that, despite working with this group of people indirectly for many, many years, it's the first time we sat in a room to meet each other. We never clapped eyes on each other until that day. We're certainly very ignorant what people can do outside in the community, and certainly they're also ignorant to our pressures. And this is very important because this is the first time we start to build relationship, and it's really about finding out what are the capabilities and facilities are there in the community. We jointly decide which patient group we want to work on, which is really in the elderly medicine category, and which wards we want these innovations to target. Together, we mapped out the patient's pathway, defined all the process and logistic, and we defined joint clinical governance with clear roles and responsibility. We agree on data collection criteria, estimating the staffing requirements, define all the outcomes and performance measures. We set up a steering team, led by myself, the clinical champion, and we decided we will have weekly meetings in order to drive the process and do troubleshooting. So we agree on a timeline for implementation, and off we go when we started in September 2010. And now I want to talk to you a bit more about what post-acute care enablement is. We call it PACE. This is very important for to make the whole thing work. PACE is an early supported discharge service which takes place in the later part of an acute episode, which is delivered in an out-of-hospital setting. And during this episode, it still remains under the auspices of the acute team, so we actually retain clinical responsibility for this group of patients while they are looked after in the community. We have on-site community case finders, which are very experienced senior nurses from the community. They're integrated into our acute team, there to pull patients from the hospital into the community. These patients must no longer require 24-hour inpatient medical care, but they have ongoing nursing and medical monitoring needs that can be safely met outside the hospital setting. The content of care is more medical and more intensive than the traditional intermediate care, and this is provider-to-provider collaboration. The aim of this PACE service is to provide an integrated model of care linking hospital with community. We thereby increase the patient's choice because a lot of the older people actually want to be in their own home, they don't want to be in hospital. We want to reduce the number of admissions, and this illustrates PACE is very important to support our admission avoidance team, treat team down in A&E. Without it, the treat team can't discharge a lot of their patients. We want to reduce the length of stay, make bed day saving, and to deliver a very high quality service at a lower cost. The PACE service is a provider-provider collaboration between the Royal Free Acute Trust, Barnet Community Services, and Camden Provider Services, which provide all the district nurses, community matrons, and the therapists. We also have London Boroughs of Barnet and Camden Social Services, who provide all the generic carers. This is where we think PACE will work in the urgent care pathway. We think PACE is going to be most important and have the highest impact at the front end in A&E, where our admission avoidance team, treat team sits, and also in the medical assessment unit, where all the acute medical emergency are admitted at first port of call. This is where we think PACE is going to have the biggest impact, and we went wrong, okay, after we analyzed all the data. To a certain extent, the elderly medicine-based ward also used PACE to shorten and shave the length of stay, but they got more time to plan their discharges. I think the slides illustrate the PACE effect very elegantly. If you look at the red line, that is the traditional way of working, and I give you a case scenario, which is patients coming in with severe constipation, very fecally impacted, gone into acute urinary retention, got an ongoing urinary tract infection, also got some care needs. In the past, they would have been admitted onto our wards, they would have to be catheterized, given enemas, would take 2 days to sort of disimpact them. Then we have to take the catheter out, see whether they can pass urine, and set up a care package and wait for social service to set it up. And it would take 4 to 5 days, I think, minimum, to send a patient home like this. Now with PACE, the patient can go home on day 1 when they're still in A&E and they're seen by the admission avoidance team, because we can put the catheter in, and basically then the PACE team will take the patient home, give the enema, do the trial without the catheter, and if they pass urine, all very good, and if they fail the catheter trial, they will refer the patient onto our urology clinic straight away. And all the ongoing social needs are actually supplied by the PACE team, so we don't actually have to wait for social services. So we already saved the length of stay by 3 to 4 days. There are lots of conditions very suitable for PACE. Just now, that one, the fecal impaction, if I have £1 for every patient that comes through, I can buy a big house. Okay, the patient coming through that is huge. But the most important message for this is these are low acuity patients. Patients with septic shock, cardiogenic shock, cannot go home with PACE. So what can PACE patients monitoring involve? They're capable of doing everything that we can do on an acute medical ward, sort of cardiac monitoring. But the most important thing that PACE do is to give intravenous antibiotics and to do blood tests in the patient's home. And because PACE patients, when they go home, they are still within the acute episode. If they didn't have PACE, they would have been stayed on the acute medical ward, and these patients will be reviewed every day on our ward round. So just like every patient, if there's a deterioration, we have to escalate the care. So if they develop cardiogenic shock, they have to move from a base ward onto CCU. And this model is repeated in the community. The PACE team acts as our medical team. They review the patient on a daily basis. So it is important for them to detect any deterioration in health. If that's the case, they have to escalate. The patients either have to be brought back to be reviewed in our clinic or have to be readmitted for us to treat them again. And the third thing, which is very important, is signposting. At the end of the PACE episode, which we set for 5 days, if the patients have any ongoing rehab or social needs, the PACE team will make that happen and direct them to the right agency. The clinical model of doing this is that we have daily MDT ward rounds on all the wards, and this is on MAU where I work, and I'm there every single day, and I sound like a parrot every morning to remind people to use PACE. Can you shave the length of stay by a couple of days by using the PACE team? So I ask this question every single day on every single patient we discuss. The patients are then identified by the medical team and agreed with the on-site pulling case finder, because they're very senior, so they know what they can, whether these patients are suitable to be looked after in the community. And once we decide that the patient is suitable to go home with PACE, a very comprehensive assessment takes place in terms of getting the consent from the patients or their relatives, checking their home environment is absolutely suitable, whether they've got food, whether they need any equipment, and we need to also, then the case finder will set up a care package which is almost bespoke to the patient's needs using the community resources. Before they get discharged, they have a very clear follow-up and escalation plan in place. So the PACE team would not take any patients home if you can't come up with an agenda. If you cannot come up with an agenda, that means the patient is not really suitable. And after you write down the agenda, you have to find a way of, if there's a problem, who do they call? So it's in hours, out of hours, bank holidays, and weekends. Then the patient goes home within 4 hours of acceptance into PACE. That includes getting all the medication and getting transport to get them home. And by the time they get home, the PACE team will have already organized the care to visit them in the same evening. And all the onward social care needs are managed by the PACE team, so we don't have to wait for social services to come up with the care package. Implementation of a project like this must be clinically led and driven, and this is the importance of having a clinical champion. You have to be there to troubleshoot, and you have to be there to be available and accountable. So there's one person to call if there's any problem. You have to focus on few cohorts, which you all have high confidence in opportunity, and in this case, frail elderly with long length of stay presents the perfect opportunity. We have to agree on evaluation measures up front and make sure you capture the data, and you have to accept that we're creating the evidence base as we go along and evolve. PACE will service a lot of operational issues, so we have to adopt a very frequent improvement cycle, so we have weekly meetings really to resolve any problems there and then, so we don't let anything fester. We have to deal with it straight away. And you can never over-engage or over-communicate with your patients and clinicians, because you have to keep explaining, because we've got a huge turnover of staff, so we have to keep explaining to people what PACE is, so that they understand the importance, how it benefits the patients, and to utilize the service appropriately. The data and outcome measures we collected is health resource groups, the number of A&E attendances, the number of admissions, length of stay, readmissions, patient satisfaction, and every single clinical incident and discharge alerts are logged and is investigated and analyzed. And after 2.5 years, now we have come up to week really in 135, but the site was made in a week 133. The patient satisfaction is very high. 90% of the patients recommend this service to their relatives and friends, and if we offer to them again, they will use it again. But most important for me is that when you ask them, do they feel safe with PACE looking after them at home rather than being in a hospital setting, the majority said they feel, the answer is yes. And this is one of the feedback questions we really focus on. As a result of PACE, beds are closed, we still got one ward closed, and the average length of stay has been reduced by 2 to 3 days per patient. And now, if you look at the bottom, the total number of patients being referred to PACE is nearly 4,000. It is in the last 2.5 years. Nearly 3,000 patients, which is 75% of them referred, we think is suitable for PACE, and we've taken home the majority of them. And the readmission rate is very low at 4%. This is for 5 days during the PACE episode. This is not a 30-day readmission. This is a very busy slide. I want you to disregard most of it. And this on the, oops, sorry, this is, where did I go? Hang on, wait, go back. Oh, no, help. Okay. No, that's not it. Okay, so on the left-hand column, these are the match cohorts by HRG. And if we go to the bottom here, this is the length of stay down here. It's 9.4 days before PACE. And now with PACE, it's gone down by nearly 2 days to 7.9. And the occupied bed days before PACE is 45,462. And it's gone down to 38,108, around that, 38,000 with PACE. The bed use at 92% occupancy has gone down from 120, this is, I'm sorry about this keep going, jumping. Yeah. The bed usage at 92% occupancy has gone down from 127 to 106. So the bed use saving is nearly 20 beds since PACE come along. The length of stay now for non-elective admission in over 70s has gone down by 2 days in the last 18 months, 2 years. And if we look at the area, which is Camden and Barnet, where we have the PACE service, the length of stay is very respectable. And we look at the bottom, in the Brent borough, which we don't have PACE, the length of stay remains very, very high at 15.7. We have very good management support. We have weekly meetings up till a year ago, when we now have monthly PACE meeting, operational meeting, which is chaired by myself. We now have an integrated care lead, which links into community and do all the liaison and all the wheeling and dealings of any things that we need to do in the community. We also still have our project manager, who is in charge of all the internal processes as we refine the process. And this meeting is attended by all the senior members of the community MDT. We report to the length of stay and QUIP steering group, chaired by our senior managers. We have continued data analysis and administration support, And we have continued funding, which started out as a 6-week pilot, is now gone on to 2.5 years. This same sort of very comprehensive management support and all the implementation process is applied to our next innovation, which is TREAT, which is Triage Rapidly Elderly Assessment Team, which is admission avoidance team based in A&E. And the lead clinician in charge of this project is Dr. Geraldine Tan. TREAT avoids admission through rapid multidisciplinary assessment and treatment. This is a 7-day-a-week consultant-led service based in A&E. They have rapid access to investigation and interventions, and also there is an also emergency social care package. They work very proactively with community teams and care homes, and they return patients safely to the community. And they have specialist nurses outreaching, and we have post-discharge phone call to enhance the patient's experience. There's also hot clinics and hotlines. This is set up on a daily basis, which is responsive to urgent referrals. So if someone phones us, we can give telephone advice. If the patient needs to be seen, they are seen on the same day, if not within the 24 hours. The aim of this is to avert crisis leading to hospital admission. TREAT is able to, the hot clinic patients can have very rapid multidisciplinary review, and they have very strong and fast link to the community, and the hotlines are actually manned by consultants, and all the GPs actually like this because we've got a single point of contact. I think what I need to say on this slide mainly is TREAT has managed to prevent admission. In the last year, look at the numbers, has increased. Last year we managed to prevent admission in 628 patients. If we didn't have TREAT, we would have to admit all these 628 patients onto the wards. So this is a very significant impact. So with TREAT, we have reduced number of admissions and length of stay, and the patient satisfaction is very high. We have attracted substantial commissioner funding. So the new TREAT team looks like this now. We've got a lot of consultants, nurses, therapists, pharmacists, data collectors, and supported by the PACE team and social services. I'm going to skip that. So what have we learned? You remember at the beginning, this is what the slides looks like. This is where we think PACE and TREAT will act. But after 2.5 years, we realized this is really not enough. This is very too simplistic. And I don't want you to be frightened by this. This is what it's become now, okay? So this is the whole system working. This is our vision for the future. And it's a quite an important slide that I'll come back to in a bit. So what we have learned is TREAT and PACE certainly reduce admission and length of stay, increase patient choice, lay foundation for integrated care, and increase capacity for us to do new business, bring in more revenue for the Royal Free. This has changed how we work and how we want to develop the new integrated system. We're now much more informed about our patients, where the gaps in care are, so that we can redeploy all our resources very effectively. We work more collaboratively with our partners, so doing everything is very easy now. And we have become very critical and demanding of ourselves. So every mistake we make, we learn from it so that we improve the process and we don't make the same mistake again. We become much more savvy in our operation, we develop a very can-do attitude, and we have much better understanding of our strengths and weaknesses for us to be more imaginative and creative with what we want to do. And we develop a pathological pursuit of excellence. So where everybody has failed, we have actually survived and thrived. What we TREAT and PACE don't do is to reduce A&E attendances and the readmission rate. We need more than that. This is what we need to do. All the gaps that are missing to reduce all these 4 targets include what is missing in the community. We don't have a robust community system to contain the patient when we discharge them or prevent them from coming in, so that to drive down attendance. How the front end work in A&E at the Royal Free is not efficient at the moment as we speak. Although we have an urgent care centre working alongside the A&E, which is funded by the Royal Free, and they see 35% of the walk-in patients when they come in. A lot of the patients sit in A&E waiting for specialty team to come and see them. And this we need to improve because we want to bring the specialists closer down to A&E like the TREAT team is now, working alongside them. And a lot of patients now actually wait in the hospital waiting for investigation because we don't trust the system, because a lot of the time when they need investigation, we felt that we lost the follow-up, so we keep them in unnecessary to wait. So there's a gap in our ambulatory care facilities and the day surgery facilities. So we need to improve on that. Sorry? We have to stop. Okay, so, right. So sorry, we have to stop. But this is how we want to work, all right? And this is the new system. You can all take a picture of this, all right? It's very, very important. So what we have done at the Royal Free, so very quickly, is that we have now established a community hub where we do case management and multi-specialty clinics, and where all people alluded to, where everybody, primary and secondary care teams work together. We have redesigned our front end. Now we actually got a £23 million project to rebuild the A&E with a co-locating of 23-hour units where all the specialty teams come and work. And also we have developed a consultant-led assessment and discharge coordination at every bit of the pathway. So you want me to stop right now? So anyway.
Alex, thank you very much. That was absolutely superb, really exemplary, and I'm sure there are lots of people who would like to ask you about it afterwards, and I'm sure you'd be delighted to share how PACE works. Fran, have we any comments on the... If you just give us a quick feedback on what Twitter tells us.
Twitter is wondering who exactly the members of the PACE team are in the community. Also, is there a maximum anticipated length of PACE involvement? And I think also, paraphrasing from some of the other comments, you mentioned at the beginning that the acute inpatient team retains clinical responsibility for the patients once they've been discharged. I'm just wondering how that works on a practical level in terms of doctors needing to give advice to patients who they can't see.
So just a quick few words here, because we really need to stop to allow people to get ready for the 3:30 session. So a couple of words just in response.
It was really, it's a 5-day episode. And during that 5 days, anything goes wrong with the patient, they feed back to us, and we retain absolutely all the responsibility in terms of changing the cares or readmitting the patient, giving advice. So after 5 days, if the patient still cannot be discharged, then it's either going to be, it would trigger a reassessment, either in the hot clinic, in our generic clinic, or at remission.
Ladies and gentlemen, thank you very much. That will bring the session to a close. Can I thank Alex and Fran? These are junior doctors. One's a core medical trainee, one's an anaesthetist. Can I thank our speakers? Can I thank Dave? And thank you very much as an audience. It's been superb. See you later.